Good afternoon, everybody. My name is King Lam, and I am a hematopathologist at Erasmus MC here in Rotterdam, the Netherlands. I welcome you all on part 6 on webinar on this time in between quotation marks reactive lymphadenopathies, and it's about T-cell lymphomas and how to get out of the labyrinth. This webinar, as the previous webinars, were made possible by the generous financial and logistic support of Recordati Rare Disease Group and the technical support of Smarty Media, for which we are thankful. We have a full webinar, about 117 registrations from 15 countries, spanning almost the globe, as far away as South America and Australia. And the topic of this webinar is not a coincidence. That's because we have reacted on the remarks on the previous surveys. So it's very important that you guys fill in the survey after the webinar, which will be presented to you immediately upon closure of the webinars. And one of the many remarks were, when do we do something about T-cell malignancies? So here we are. May I have the next slide, please? These are my disclosures. Of course, everything I say, I have to put it up for a few seconds so that everybody can see them. May I have the next slide, please? Now, I have used this image and this question in the previous seminars, and which disease is most likely not associated with this image? And I give the right answer immediately. That's A, idiopathic multicentric Castleman disease. If you think of a multicentric Castleman disease and you see these kind of type of cells, I would suggest you reconsider the diagnosis immediately and consider one of the other alternatives, which is listed below. And if you look at those alternatives, you see you see 3 T-cell lymphomas. You see at least 2 T-cell lymphomas with a differential. So it's quite important that you think of a T-cell lymphoma when you see rare cells, and I know it's difficult because T-cell lymphomas are rare. Only 15% of the malignant lymphomas are T-cell lymphomas. Up till now, we have a lack of knowledge. At least it's not so extensive as the knowledge on B-cell lymphomas. So we actually, up till quite recently, we did not know what to look at. However, the knowledge is increasing, and that is reflected in the classifications. Actually, we have 2 new classifications upon which we are not going to discuss this webinar, and the therapy has become more targeted and more sophisticated, I would say, even more personalized. So making a correct diagnosis has become even more important. May I have the next slide, please? So the program, it will be very simple. Professor Toussaint will start the webinar and try to teach us how to get out of the labyrinth especially using immunohistochemistry. So it's how to get out of the woods, so to say. And the second part will be by Professor Dieriks, which will give a lecture on how to treat the T-cell lymphomas using personalized algorithms. And the last one is by Professor Tiemann, who will try to give us pointers how to even recognize when we are in the labyrinth. So with that, may I have the next slide, please? Some housekeeping remarks. The content is, of course, the responsibility for each presenter. Please answer the questions of the presenters. They are not so much. You can submit your questions in the Q&A online. We'll try to answer them after each presentation. And please fill out the survey, which is will be presented to you after the webinar, immediately after the webinar. And with that, I will introduce Professor Thomas Toussaint. Of course, he needs no introduction at this stage. Professor Toussaint is a professor of pathology at the Catholic University of Leuven, with a strong focus on hematopathology. He has served and is serving in various roles in Belgian and European societies of pathology, especially dealing with teaching. And he is also an EXCO member of the board of the European Society for Hematopathology, and has many, many years of experience in practicing and also teaching hematopathology to fellows, residents, and students. And Professor Toussaint will show us how to get out of the labyrinth when we are diagnosing T-cell lymphomas, highlighting the use of immunohistochemistry algorithms. Thomas, the web space is yours.
Okay, thanks, King, for this kind introduction. I hope everybody is seeing my screen.
Yep.
So I will indeed try to give a kind of overview on the classification and the diagnostic approach I use for T-cell lymphomas, and I will mainly focus on the T-cell lymphomas presenting in lymph nodes. So there's, as you know, there's many types of T-cell lymphomas also outside of the lymph node, but today I will mainly focus on the nodal presentation. So this is these are my disclosures. I also would like to thank Recordati for organizing this kind of meetings, which serve to a lot of practicing pathologists and hematologists. So today, this is the outline of my talk of today. So after giving a definition of a T-cell lymphoma and introducing the current classification of T and NK cell lymphomas, I will give you some insights on how I personally establish the diagnosis of T-cell lymphoma involving lymph nodes. And although I'm not a big fan of using immunophenotypic algorithms, I will try to give at least kind of a step approach, a multi-step approach on how to deal with this kind of lesion, because as King indeed mentioned, these are not so often not so easy to diagnose. They're not so frequent. So that makes them sometimes kind of difficult to diagnose. And I will, use some live cases to illustrate some of these lymphomas. So first, the definition. So a T-cell lymphoma is a very heterogeneous and often clinically aggressive group of lymphomas derived from mature T cells. They comprise about 10 to 15% of all non-Hodgkin lymphomas. And one important criterion in defining some of the T-cell lymphomas is the anatomic location. And so as you can see in this overview, I try to make from the last 22 ICC classification is, as you can see, that some T-cell lymphomas will predominantly have like a disseminated or leukemic presentation, while others will mainly present in extranodal or in cutaneous areas. But today I will focus on the nodal, so the primary nodal involvement by T-cell lymphomas, but also take into account that all the lymphomas that are mentioned here will or might eventually at some point spread to lymph nodes. So if you have a T-cell lymphoma in a lymph node, it can also be like a nodal manifestation of one of the lymphomas mentioned here. But today I will mainly focus on the primary nodal T-cell lymphomas. So in the 22 ICC classification, there are some minor changes compared to the 2017 WHO edition. And I will quickly go over them. So the three lymphoma subtypes that were derived from follicular T helper cells, they are now grouped together. And so they are considered three subtypes of what we call TFH lymphoma. So we have an angioimmunoblastic type, a follicular type, and an NOS type, while in the previous WHO, they were kind of separate entities. They are now, it is now assumed that they represent a single entity, and there were no major changes in the diagnostic criteria for these TFH lymphomas. Regarding the ALCL, so the anaplastic large cell lymphoma, there is still the ALK positive and ALK negative group. No major changes in the diagnostic criteria. The only thing that is worth mentioning is that there is a subgroup, a molecular subgroup with a DUSP22 rearrangement, which is now considered a genetic subtype of systemic ALK negative ALCL. And the other groups like the TP63 rearranged cases and others require some further study before being allowed to be a different subtype. One major change is that in the previous WHO, there was a variant of PTCL-NOS that was EBV, Epstein-Barr virus positive. And so in the new classification, it is considered a separate entity. So it's still provisional in the 22 ICC, but it should be discovered or should be designated distinct from PTCL-NOS. And so it's called primary nodal EBV positive T and NK cell lymphoma, so separate from PTCL-NOS. PTCL-NOS itself remains like a wastebasket or a diagnosis of exclusion. There are some molecular subtypes that have been identified, the TBX22 group, the GATA3 subgroup. In most routine clinical practice, this is not assessed at this point, but this might be in the near future. And then there is one other remark. So the EBV negative but cytotoxic PTCL cases, they might represent a distinct subgroup and require further study. So this might also be important to identify them. So this is a bit the overview of the cases I will discuss today. So the diagnosis of a T-cell lymphoma is usually established like other lymphomas based on either morphological, immunophenotypic, and genetic features. So morphological features that are often seen in a T-cell lymphoma is architectural effacement by cytologically atypical T-cell proliferation, often of medium to large size with irregular nuclear contours. And what's important in T-cell lymphomas, and which makes it sometimes very difficult, is that they might contain a considerable amount of inflammatory background. It's very well known that you often see eosinophils in the background that often give the clue to a diagnosis of T-cell lymphoma, but also other cells, lymphocytes, histiocytes, plasma cells might be seen and often blur the image of a T-cell lymphoma, particularly, for example, in angioimmunoblastic T-cell lymphoma, there might be very numerous plasma cells which blur at first instance the image, so the diagnosis of for example, angioimmunoblastic T-cell lymphoma. Regarding the immunophenotype, well, we need at least one or more PAM T-cell markers, but know that one of the diagnostic criteria that we can use is the loss of certain mature T-cell markers. Normally, there should be no expression of PAM B-cell markers, although there might sometimes be a little bit of B-cell marker expression. So it's always important to at least perform multiple markers of B or T-cell lineage in order to start your process by defining is it mainly a B-cell or a T-cell lymphoproliferation. Then there is an important role for EBER. So not only to define the T cells to make the diagnosis of the primary nodal EBV positive NK T cell lymphoma, but also to find EBV positive B cells, because sometimes it will be a difficult differential diagnosis if we see many EBV positive B cells, like, for example, in the background of angioimmunoblastic T cell lymphoma or PTCL, or there might sometimes be difficult cases of classical Hodgkin lymphoma, EBV positive cases that contain a lot of T cells with a follicular T helper phenotype. So there's an important role always to include EBER in your diagnostic panel. Then there is a very important role for CD30 in the diagnosis of or in the classification of T-cell lymphomas, and we generally divide on the one hand the cases that express strong and uniform by virtually all neoplastic cells, CD30, or the cases in which there is partial, weak, or no CD30 expression, and that will be important in the rest of my talk. Then there is some markers that normally are not expressed by lymphocytes, like, for example, ALK, related to an ALK rearrangement, for example. There are the TFH markers, some of which are more sensitive than others. These are the mostly used follicular T helper cell markers. And then we will also include follicular dendritic cell markers, and I mainly use CD21. There are markers available to detect cytotoxic molecules like TIA, granzyme B, perforin, and there are some NK cell markers available. Clonal T cell receptor gene rearrangements will often support the diagnosis of a T cell lymphoma, although cases of ALCL, for example, can be in germline configuration and show no clonal gene rearrangement, or the reverse. There are cases of reactive conditions or autoimmune conditions where you can identify monoclonal or oligoclonal T cell populations in a case that is not lymphoma, of course. And then genetic assays, they need to be interpreted together with clinical and histopathologic findings, because you can find some mutations that are seen in the absence of lymphoma, for example, cases with clonal hematopoiesis. And then there are some specific genetic findings, for example, the detection of ALK rearrangement in ALK-positive ALCL, or the detection of RhoA mutations in follicular T helper cell lymphoma. So this is a bit an overview of how we diagnose T cell lymphoma. Now I'll go a bit more in detail. I generally use a four-step approach. First, I establish the cell of origin, which in this case will need some T cell markers to establish the T cell origin. I perform an EBER to check for either T cells or B cells infected by EBER. I check the expression and also the pattern of CD30 expression, and then according to the expression pattern of CD30, I proceed with ALK and cytotoxic markers, with TFH markers and CD21, or some NK and T cell or cytotoxic markers. So in cases in which there are T cells expressing EBER, they will generally also express cytotoxic markers. So in that case, if we find EBER positive T cells, it's important to correlate with the clinic of the patient, because some of the diseases mentioned here will mainly arise in children or young adults. So that's an important point. It's important to check for the presence or absence of a nasal mass, and for systemic symptoms. So the so-called HLH, so the hemophagocytic lymphohistiocytosis or hemophagocytic syndrome. These are things that are important to check in order to interpret your image. On the immunohistochemical level, so like I said, most of these cases will express cytotoxic markers, and then it's important to check for NCAM, for CD56, to help us differentiate between the provisional new entity primary nodal EBV positive T and K cell lymphoma, or a lymph node involvement of one of the other EBV driven T or NK cell entities. So that's the first part. That's for cases that are EBER positive. In case the T cells are EBER negative, it's important to check CD30. If there is CD30 expression in nearly all cells in a strong and uniform expression matter, then it's important to perform ALK. ALK and cytotoxic markers, if they are present, they will guide you towards the diagnosis of an ALK-positive ALCL. In the absence of ALK, the differential will be a bit more difficult. There will be a differential between either an ALK-negative ALCL, but ATLL can be in the differential diagnosis. There can be lymph node involvement of some transformed mycosis fungoides, an ETL spreading to the lymph nodes, an cutaneous ALCL spreading to the lymph node, the breast implant associated ALCL spreading to the lymph nodes, or the category PTCL NOS, in which we see an increased number of EBER or CD30 positive cells. So this will be a bit more challenging to detect these or to further differentiate. Will of course largely depend on the clinical presentation, if we have a history, of course. If there is no prominent CD30 expression or only weak and variable, then it's important to check for T helper markers, and not only T helper markers, but also for follicular T helper markers. So ICOS, PD1, CD10, BCL6. And in order to come to the diagnosis of a follicular T helper lymphoma, there is at least 2 of these TFH markers that need to be positive. So that's important. If there is more than 2 present, this excludes the diagnosis of PTCL-NOS. And of course, it's difficult to make a diagnosis if we have only 1, for example, TFH marker. If there is no expression of CD4, so if we are entering the category of the cytotoxic T cells, there will often be CD8 expression and expression of cytotoxic markers. Then we will perform some NK cell markers, check for TCR beta or TCR delta in order to further try to differentiate the possible entities. So this is a bit the overview of how I approach, and now we will go over some cases in order to illustrate this process. So the first case is elderly man, no relevant medical history, no immune deficiency, but presents with a very bulky nodal disease in a stage 4, so very prominent lymphadenopathies, focal splenic involvement, liver involvement, a patient that is very ill, that shows also signs of hemophagocytosis. And we received a lymph nodes of this patient. So I will now try to switch to the cases. I hope you can see the cases. So all cases are made available. The scanned images are made available for everyone. So this is case number 1. And so you see, this is a largely disturbed lymph node architecture. Here there is some diffuse disturbance. There is infiltration of the fat. There are some areas of necrosis present, as you can see here. And if we look at the neoplastic population itself, it looks like a large cell population, lots of apoptotic debris, lots of mitosis, large cells, not so many infiltrating non-neoplastic cells. So a very diffuse large cell proliferation with some striking apoptotic debris. So that is very prominent in this case. And we have the areas of necrosis. So everybody is invited after the lecture to look at these cases in detail again. So, but now I will discuss the features of this case. So here you see an overview of this case, some more details like I showed. And so now I would like to ask some assistants to start a poll to check on your first ideas. So based upon this H&E with these large cells, with the necrosis, with the very prominent apoptosis, what would be your preferred diagnosis? So as we can see here, there is nearly all answers or all possible options have been at some point addressed. A lot of people consider PTCL-NOS, DLBCL-NOS. Well, I think that the majority of the options are possible based upon the H&E, and this is clearly reflected here on the poll. So now let's go into a bit more detail and see if we can narrow down the diagnosis. So first of all, step 1, try to establish the cell of origin. I can tell you that the cells were tested for multiple B-cell markers and they express no B-cell markers and no plasma cell markers. But we see the expression of multiple T-cell markers, including CD3, including CD2, including a weak CD7. They show an alpha-beta TCR rearrangement, a very high proliferation index, and loss of CD5. So pointing towards some kind of malignant T-cell lymphoproliferation. Second step is to determine the CD30 in this case, and this was completely negative. So if we follow our algorithm in T-cell lymphomas expressing no CD30, we express then the different T-cell subsets. As you can see here, there were some intermixed histiocyte staining on the CD4, but the lymphoid cells themselves, they clearly show a cytotoxic phenotype, so expressing CD8, expressing cytotoxic markers like TIA1, coenzyme B. They show no NK cell markers and no plasmacytoid dendritic cell markers, excluding or making the proposed diagnosis of Kikuchi, of course, unlikely. PCR was performed and it showed clonal T cell receptor gene rearrangement, and NGS showed a mutation in TET2 and DNMT3A. So if we look at our list, I think given the T cell receptor or the T cell receptor gene rearrangement, T cell marker expression, the clonality, I think we can exclude the first 4, but we still have the possibility of the lesions mentioned below. So, of course, I proposed you a 4-step algorithm, but I forgot the first step, of course. And if you look at this Eber stain, we clearly see a nearly uniform expression, nuclear expression of Eber, and an expression of LMP1, but not EBNA2, so showing an EBV-driven T cell proliferation with a latency type 2. The bone marrow that was also involved could show some double staining, so it are the CD8 positive cells expressing the Eber, and we also found multiple histiocytes with signs of hemophagocytosis. So going back to the algorithms I showed, we have a Eber positive T cell proliferation with cytotoxic markers. There was no nasal mass, there was no expression of CD56, and there was expression of CD8. It was an elderly patient, so this excludes the systemic EBV positive T cell lymphoma of childhood, and so we end up in the diagnostic category of primary nodal EBV positive T NK cell lymphoma, and also the mutation that was found has been described in this entity. So for those who are not familiar with this entity, I introduced this one slide. So such lesions, they were previously categorized in the WHO as a subtype of PTCL NOS, but so now both in the WHO 5th edition and in the 22 ICC, it's considered a separate entity. It's a rare disease. It's mostly occurring in elderly patients from Eastern Asia, often associated with immune deficiency. And as the name in the 22 ICC clearly states, it's primary nodal, and that is important, that this is a disease that occurs primarily in lymph nodes. So it can occur in some extranodal sites. It might occur in Waldeyer's ring, and then it can be misdiagnosed as an extranodal NKT cell lymphoma, but it should have no nasal involvement. That's important. It should also not be diagnosed in children where we have other EBV positive T and NK cell lymphoproliferations with nodal involvement. As the case I showed, most cases will show a very monomorphic growth pattern with very atypical cells, lacking the typical angiodestruction as seen in extranodal NKT, although, like in this case, there might be necrosis. They are mainly of T cell lineage with a cytotoxic T cell phenotype, but they are usually CD56 negative in contrast to the extranodal NKT cell lymphoma, which is, of course, CD56 positive. There will be an EBV latency type 2, and these patients, mainly because of this hemophagocytic lymphohistiocytosis that is often associated, will have a very poor outcome with a median overall survival of less than half a year. So that is an entity important to recognize and which you can quickly pick up if you had followed the second step in my algorithm by performing Eber once you have a monomorphic T cell proliferation. So this was case number 1. Case number 2 is different situation. This is a 37-year-old female, so a somewhat younger patient. She has a history of melanoma, of the left lower leg, and now she presents with B symptoms and with very hypermetabolic lymphadenopathies, supra and retroclavicular area, retropectoral area, and left axillary area. And so we received an axillary lymph node. Oops. Let's go back to this slide. So this is so we see a somewhat thickened capsule, some vaguely multinodular appearance of this lymph node. And then if we look somewhat closer, we see very large cells, very atypical cells. Also, again, lots of apoptosis. So very large cells. Sometimes they have the impression to grow in some kind of cohesive or pseudo-cohesive pattern. So this shows this vague nodularity in this sample. And what was interesting in the background that we don't see any eosinophils. We don't see, but we do see lots of plasma cells in the background. So let's go to the immunophenotype. So here you see again all this kind of plasma cells in the background. No eosinophils. These large cells, irregular nuclei, often vesicular. We did not see any clear donut cells. Some show this kind of retraction artifacts. But as you can see here, lots of plasma cells in the background. And so the first step, again, establish the origin. So first we did the first round of immunos, and we could not establish the exact origin. Cytokeratin was negative, S100 was negative, given her history of melanoma. No expression of CD3 and no expression of PAX5. So no origin that is very clear. So I would like to ask for some assistance to get your opinion on this case. So very somewhat vaguely nodular appearance, large atypical clusters of pseudo-cohesive cells. Mona, can I have your assistance for the poll? So most are in favor of an ALK negative ALCL. Let's see. So we further elaborated. So we did the second round of immunos, and what we did found was one epithelial marker, EMA, that was positive. And we did found some negative other T cell markers, but there was also some weak CD5 and some CD4 expression. So there seemed to be a predominance, or at least the expression of two of the mature T cell markers, and it was supported by PCR. So there was T cell receptor clonality. So we could define that this was a T cell origin. So the first step was done. It was a T cell or presumably lymphoma of T cell origin. So second step was EBER. So now we did it, but it was negative. And the third step is performing CD30 and looking at the pattern. And as you can see here, there is a very diffuse, very uniform expression of CD30, no expression of CD15, for those who would still consider the option of syncytial variant of Hodgkin. PAX5 was also negative, by the way. There was expression of several cytotoxic markers, and there was expression of ALK. So ALK was here present in both a nuclear and a cytoplasmic pattern, and FISH confirmed an ALK NPM rearrangement, and so we could deliver the diagnosis of an ALK positive ALCL. Case number 3 is a bit more challenging case because it illustrates that these T cell lymphomas, they can have a very subtle growth pattern. So case number 3 looks largely reactive. We have reactive germinal centers in the periphery. We have a kind of reactive paracortical area. But when we looked, particularly here in the sinuses, in the marginal sinuses, we discovered some larger cells. And at first, we thought maybe they might be histiocytes, because there were no clear hallmark cells. But then we found some mitotic figures, some apoptosis. And so we further investigated this case. So again, with this pattern, you could definitely think of a kind of a metastatic disease, a melanoma, a carcinoma, given this very important sinusoidal infiltration pattern. And so if we performed our different steps, checking the T cell origin, no CD3, no CD2, but there was CD5 expression. There was very strong and diffuse CD30 in this very prominent sinusoidal pattern. And again, expression of ALK. In this case, it was only cytoplasmic ALK. But I just wanted to share this case with you, because if you look at the CD30 at low power, you see that the majority of the lymph node is not involved. So this is a very early infiltration of this lymph node, mainly in this sinusoidal pattern. And it's, well, given away by looking very carefully in the sinusoids and by confirming, for example, CD30 in this case. So interesting features of these two ALK positive ALCL features is mainly that both morphologically, by their either cohesive growth pattern or by their sinusoidal growth pattern, they can mimic a carcinoma. And also, there might even be cases with some cytokeratin expression, but EMA is very often positive and should not be confused because EMA, epithelial membrane antigen, as the name says, that you do not mistake this for a metastatic lesion, particularly when this is not in your, well, when the clinician is not really considering lymphoma. You should definitely look very good at the different features of this lesion. Then case number 4 is also is a 59-year-old male presenting with hypermetabolic lymph nodes in the right axillary area, but not only in the lymph node, it also has, if you look at the lower leg here, there is a very hyperintense lesion intramuscularly at the left lower leg, and there's also one in the muscle of the right upper arm. And so we received a biopsy from this case. So this is case number 4, where if you look at the case, it's very diffusely infiltrated, very monomorphic, large cells, very numerous mitotic figures, no clear hallmark cells, no Hodgkin-Reich-Sternberg cells, very sparse reactive infiltrate in between, so no eosinophils, no plasma cells, so very diffuse large cell infiltrate infiltrating the periglandular fat. Very numerous mitosis, so it looks like a very high-grade process. And so always the same, try to establish the origin. We performed several B-cell markers, they were negative, and nearly all T-cell markers were negative, as you can see here, except for CD4. That was positive, but as you know, CD4 might be some kind of, sometimes a bit of a promiscuous marker, particularly because it also stains histiocytes. There was also very strong MUM1 expression. And if we looked at the PCR, both IgH, IgK, and T-cell receptor, they all turned out polyclonal. So we could not definitely establish the T-cell origin, although the CD4 seemed to be, well, convincing membranous stain. We performed our second step, EBER. EBER was negative. And looking at the CD30, we have again a very strong and uniform expression pattern. So we continued. We performed ALK. ALK was negative. We performed cytotoxic markers. It was negative. We performed TFH markers. They were all negative. The only stain that turned out to be positive was P63. And so all the stains mentioned here remained negative. So we have a very monotonous large cell malignant proliferation with expression of CD30, CD4, MAM1. And so now I would like to have your ideas on what could be the diagnosis here. Again, a very widespread overview. I see plasmablastic lymphoma, presumably because of the MAM1 expression. That's a very good candidate. Although the cells did not look very plasmablastic, PTCL and OS as with a lot of CD30 expression, okay, ALK negative ALCL, a nodal localization of a primary cutaneous ALCL, of course, if we would have a history, and maybe the muscle lesions could maybe somewhat point towards that diagnosis. So all good suggestions. So let's see what we turned out to make the diagnosis, to what diagnosis we turned out. So we got some help from our cytogeneticists, where they the karyotyping showed a very complex karyotype, but with some aberration on chromosome 6, and we could illustrate a balanced rearrangement of the locus containing DUSP22 and IRF4. They are very close to each other. So the break-apart FISH probes that are generally used are not able to distinguish clearly whether it's a DUSP22 or an IRF4 rearrangement. That's why they are always mentioned together. And IRF4 rearrangement or DUSP22 rearrangement, they are or they can be seen in this entity, so ALK negative ALCL. But notice that there are also other entities that can have this rearrangement. So in the context of B-cell lymphomas, there is this IRF4 rearranged large B-cell lymphoma. Cytotoxic PTCL, ALK negative ALCL can show this this rearrangement. And so in order to come here to a final diagnosis, we had to, well, make some or overview some criteria, and there are some suggestions on how to make now a distinction between an ALK negative ALCL compared to a PTCL with prominent CD30 expression. I think in this case there was very diffuse and homogeneous CD30 expression. CD30 can be seen in PTCL. It's often not so prominent, I think, as in this case, but other features that can be used is like the sinusoidal growth pattern that has been shown in one of the cases, cohesive growth pattern, the presence of hallmark cells could favor ALK negative ALCL. Reduced T-cell surface antigen expression. In this case, this was very much reduced. EMA expression I did not show, but it was also present in this case. And a cytotoxic phenotype is generally well associated with ALCL, but the DUSP22 rearranged cases often lack presence of cytotoxic molecules, and that makes it, of course, very difficult. So know that I always use cytotoxic molecules to make this distinction, but know that this does not exclude this entity. So even if you don't have cytotoxic molecules, go ahead and perform FISH to check for a DUSP22 rearrangement. In the ALK negative ALCLs, there's about 1 on 3 having this DUSP22 rearrangement, and know that it has a prognostic implication. So patients with a DUSP22 rearrangement, they have somewhat a similar overall survival as the ALK positive ALCLs. And they do much better than the cases that have a TP63 rearrangement, which is another gene that is rearranged in some cases of ALK negative ALCL. So interesting features here on ALK negative ALCL. It can be a mimicker of plasmablastic lymphoma, mainly because of MAM1 expression. Also EMA can be seen in plasma cells. We did an overview of a lot of plasmablastic lymphomas, and we found that some of these cases can contain some T-cell marker expression. So try to find other ways to exclude plasmablastic lymphoma. In this case, we performed BLIMP1, CD69, 79A, and other plasma cell markers. We had no kappa lambda, so there was no evidence that this was a plasmablastic lymphoma. The DUSP22 rearranged cases do not always express cytotoxic markers. This is important to note. And of course, check the history for example, cutaneous ALCL, which would help, of course, your diagnosis. And then I think this is the last case I will present is a case of an elderly female, 77-year-old, multiple. Excuse me.
Make it fast, Thomas.
Okay, or I can stop if you like. Wait, I will stop here in order to respect the other speakers, but I might just go to my summary slide. You can go to the case. It's a very interesting case. I will give away the diagnosis afterwards. So these are the lymphomas that we mainly see in the lymph node. So I have put on the web on the platform some cases for each of them. And the take-home messages I would like you to take away from my presentation is to include EBER-ish always, to, on the one hand, detect the primary nodal EBV-positive T-cell lymphoma, or to check for EBV-positive B cells. Beware of the mimickers, either morphologically or at the immunohistochemical level. Always be careful with algorithms. Know that CD30 is an activation marker, not a tumor marker. And that's also something I did not mention, but I think Marcus might go into detail, is the presence of TFH markers, which is can be a difficult or tricky evaluation, because expression of PD-1 and ICOS is not specific for TFH cells. It can be seen in T cells and cytotoxic T cells that are exhausted. So in cases with chronic immune stimulation, so be very careful. Not only to base yourself on weak PD-1 expression to make a diagnosis of a TFH lymphoma. Use the PCR result with care. Know that ALCL can be polyclonal, like I showed in one of the cases. And as always, clinical pathological correlation is clue to interpret and come to a final diagnosis. And this is some literature that I could advise and that I can provide you with. But now I will leave the floor to the next speaker. And thank you very much for your attention. And if you have any further questions, I'm more than happy to answer them after the talk.
Thank you very much, Thomas, which made me think that I have to check my sinuses very carefully now. But I have there are two questions. I will pose one to you and one in the discussion. The first is probably more burning from the audience. Can you shortly comment on the use of LMP1 instead of EBER? I have my opinion, but we are curious of yours.
Well, there's two things that I can say there. EBER should be the gold standard to assess EBV positive lesions. Why? Because EBER is also present in cases in which you have a restricted latency. So LMP1 is one of the viral proteins, and they are expressed in some lymphoma types, like for example in Hodgkin, in some EBV positive DLBCLs, and in cases in patients with a strong immune suppression. And so in these cases, it's well, you can use LMP1 only. But there are also other lymphoma types where, for example, the EBV positive Burkitt lymphomas, where there is no LMP1 expression, but is an EBER or is an EBV driven lesion. So, and then one remark on EBER. For EBER, in order to interpret EBER, it's always important to check viable cells, because you need RNA for this test, and so only viable cells will express RNA and will be positive. So that's an important one. We used in the past, we used to use an RNA control always on our slides, so a poly A tail to check for RNA quality. But now we left that out. But always include an external control, a positive external control, and then well, So that's the advice I can give on IBR and LMP1.
Thank you very much. We hope, don't go away. We hope to tap into your knowledge later on in the discussion. Thank you very much, Thomas. And it's now my pleasure to introduce Professor Dan Dieriks. Dan Dieriks is the head of the Laboratory of Experimental Hematology at the Catholic University of Louvain. If you look at the website, you will see that he has a very substantial clinical and translational research contribution in the areas of PTLD and T-cell lymphomas, and always focused on genetic events that can provide therapeutic options. So in that sense, a real clinical doctor. And he is also heavily involved in teaching of medical students and residents, and has many contributions in this field. And Professor Dieriks will present the challenges in the treatment of T-cell lymphomas, especially in the era of personalized medicine. Dan, the web space is yours.
Thank you very much for the kind introduction and for the invitation. Can you see my slide?
Yep.
Yeah, perfect. Thank you. So good evening, everyone. So I will talk about challenges in the treatment of T-cell lymphomas. These are my disclosures. Does it change the slides? Because here with me they don't change, but do you see now the new slide?
Yep.
Yeah, okay. We will start with the question. I know there are a lot of pathologists here, so it's a clinical question. I don't expect that you know the answer at this point, but I will hope that I can explain the right answer during my talk. But we will do a first vote now, a first poll now. So the question is, which new first-line therapy has shown a statistically superior 5-year progression-free survival compared to the standard CHOP chemotherapy? One is CAR T therapy against CD5 in nodal T follicular helper lymphoma. 2 is brentuximab vedotin combined with CHOP without vincristine in ALCL. 3 is romidepsin, which is a HDAC inhibitor combined with CHOP in PTCL-NOS. 4 is pembrolizumab, a checkpoint inhibitor in EBV-positive NKT cell lymphomas, or 5, none of them. Okay, can we see the answers? That was the answer already. Okay, but I mean the poll. But this. Okay, let's start. So I don't think it's possible to talk about clinical aspects of T-cell lymphoma without mentioning the huge effort and the huge contribution of the International Peripheral T-cell and Natural Killer T-cell Lymphoma Study. It's actually an initiative taken by 22 large centers worldwide to look at epidemiology, incidence, clinical pathological characteristics of patients with newly diagnosed T-cell lymphomas. And here you see that actually we have 5 large groups of T-cell lymphomas. You have the peripheral T-cell lymphomas, you have the angioimmunoblastic lymphomas, you have the NKT cell lymphomas, the adult T-cell leukemia or lymphoma, and then these groups, we will combine them. It's the ALK positive and the ALK negative anaplastic lymphoma, anaplastic cell lymphoma. And then you have a lot of many other subtypes like the subcutaneous panniculitis-like, hepatosplenic, and so on, but they are really very rare. But it's important, and I think Thomas already told about that there is also a geographic distribution. And here you see in this table that actually NKT cell lymphoma and ATLL are mainly seen in Asian countries and less in the Western. So in North America and in Europe, you don't see those subtypes very often. So when we look at our population, I think the 3 main important ones are the nodal ones, the angioimmunoblastic, I call it the old terminology at this point, then the anaplastic large cell lymphoma, and then the peripheral T-cell lymphoma NOS. And when you look at data from the state registry data, actually there is an estimated incidence of a nodal T-cell lymphoma of about 0.25 cases per 100,000 people. So it's considered a T-cell lymphoma a very rare disease, fortunately. And this has already been told by Thomas. So we have the old or the revised 4th edition of the WHO classification from 2017. And now we have 2 other classifications, ICC 2022 and the new WHO classification. There is a discrepancy in some terminology, like the follicular helper T-cell lymphoma is called in the WHO the nodal T follicular helper cell lymphoma, but basically many aspects are the same. It's just a matter of terminology. And Thomas already told this, you can also divide T-cell lymphoma in the place where they occur. So you have the nodal ones with the 3 main subtypes. You have the extranodal with the most commonly the EBV positive NKT cell lymphoma, called formerly the nasal type. Then you have the cutaneous ones, different subtypes, and then you have the leukemic ones, which are mostly very, very aggressive. From a clinical point of view, actually, nodal, extranodal, and leukemic subtypes are considered aggressive. Not all. You have some indolent ones, like, of course, the indolent T-cell lymphoproliferative disorders of the gastrointestinal tract, like, for example, most T-cell LGL leukemias. But in general, they are considered aggressive, whereas the cutaneous, also with some exceptions, are considered more indolent. And this was also already discussed by Thomas. Actually, when you divide the nodal ones in the main important subtypes, you will see that actually there are molecular genetic aberrations which are more specific for specific subtypes. So, for example, the T follicular helper cell lymphomas, they are characterized by epigenetic aberrations or mutations, and we will see that this may lead to different treatment options in the future. From a clinical point of view, the median age of diagnosis of most T-cell lymphomas is about 60 to 70 years, except from some subtypes like the ALK-positive anaplastic large cell lymphoma, which is mainly seen in younger patients, in children, and in adolescents and young adults, and also the hepatosplenic T-cell lymphoma and the extranasal NKT cell lymphoma is more seen in younger patients. But in general, the huge majority of T-cell lymphomas are seen in the, I won't say in the elderly population, because it's not the elderly, it's the adult population of about 55 to 65 years. There is a predominance of male gender compared to the female gender. And as you can see, many patients, except for some specific local, like the nasal type, like, of course, the primary cutaneous, which are considered stage 1 or stage 2, but the others, the most nodal types, are diagnosed in advanced stage, so in stage 3 or 4. And often the bone marrow is positive. When we look at prognosis and when you compare it to, for example, B-cell lymphomas, T-cell lymphomas are considered to having a very poor prognosis. You can see here overall survival curves, and you see this for the most common subtypes. Most subtypes have a very poor prognosis, except for the ALK-positive anaplastic large cell lymphoma, who have a more favorable prognosis. The same in the very rare subtypes. Most have a very poor prognosis, except for most cutaneous subtypes of T-cell lymphoma. And you have different prognostic. I won't go into detail, but you have the classical International Prognostic Index, which is actually validated in aggressive lymphomas, most commonly in B-cell lymphomas, but it's also a good prognostic score in T-cell lymphomas. But then you have also specific T-cell lymphoma. You have the peripheral T-cell lymphoma specific prognosis index. You have some international T-cell lymphoma project prognostic factors. But in general, the more advanced the stage, the poorer the performance of the patients, the older the patients, the less prognosis they have. So this is a general introduction. The main focus of this presentation will be on treatment. And I will start with what's the optimal frontline therapy. And there is a question mark because actually we don't know the optimal in contrast to the classical R-CHOP in diffuse large B-cell lymphoma. We don't know the optimal frontline therapy. Is there a need for consolidation therapy? And especially, is there a need for consolidation with autologous transplantation for T-cell lymphoma? What in case of relapse or refractory patients? And then, of course, I will talk about the new treatments, the targeted treatments, the immune therapy with the antibody drug conjugates, kinase inhibitors, the epigenetic therapy, cellular therapy, and checkpoint inhibitors. So first, let's start with the frontline therapy. And these are some large registries. So you have the international, but you also have Swedish registry, the Netherlands, the Dutch registry. And as you probably know, in the 90s, the standard of care for all lymphomas was CHOP. So it's not surprisingly that the backbone of all those treatments in T-cell lymphoma was also CHOP. So you can see that actually the majority of patients in those registries in first line were treated with CHOP or CHOP-like therapy. But as you can see, the prognosis, the 5-year progression-free survival, the 5-year overall survival is very poor, except for the ALK-positive anaplastic large cell lymphoma. Actually, we still don't know whether it's because of the ALK positivity or is it because of the patients are younger. Initially, it was thought that it was because of the ALK positivity, but more and more data show that actually it's because patients are younger, that this is a very important prognostic factor. But in general, very, very disappointing results. So there is need for better treatments to improve the outcome of these patients. And one thing which was added was etoposide, because etoposide is a chemotherapy which is very toxic for T cells. So there is a tendency, and here you see one trial, when you see that from 2010, 2015 on, there is a tendency to add etoposide to CHOP chemotherapy for patients with T-cell lymphoma. And actually, there has been a lot of controversy. Some studies show actually a better outcome when you add etoposide. Some show not a better outcome. And you also have to consider that adding etoposide adds toxicity to the patient. So it's a toxic regimen. You can't give it to patients with 70, 75 years old because it's too toxic. But when you look at all the studies, actually the subgroup who has most benefit from adding etoposide are the ALCLs, both the ALK positive and the ALK negative. They do better when you add etoposide to CHOP. The other ones don't seem to benefit that much from adding etoposide. It's also important because these are worldwide studies that it includes all what we thought in the 90s and the first decade of this century that were considered PTCL. So for example, the EBV positive, I used the WHO and the provisionary term from the ICC. So the EBV positive nodal or the primary nodal EBV positive T-cell and K-cell lymphoma, they were not included. And we now know that they actually have a totally different, that's also why they are considered separate entities. They have another mechanism with PD-L1 upregulation. They are less genomic unstable compared to other lymphomas or T-cell lymphomas. They are characterized by NF-κB activation. So these seem to be different, and that's also the reason why they are considered a different entity. But they were actually all included in, especially if you look to Asian studies, they were actually included in the PTCL group. Is there an improvement when you add consolidation therapy with autologous transplantation? Again, a lot of studies, especially retrospective studies, with patients between 10, 20, 50 patients. And here you see the result. Is there a benefit? Some say maybe, some say yes, some say no. It's actually not clear. And this is also reflected by the recently published National Comprehensive Cancer Network guidelines, which say that if you have a patient who is been treated with CHOP or CHOP, whatever, is in a complete remission after the first line, you can observe and do nothing afterwards. You can do an autologous transplantation. You can consider a clinical trial. So actually, there is no standard of care. And some centers will go to autologous transplantation, others won't go. We have some more information from the complete trial. That's a trial which only included the nodal ones, so the most commonly here in the Western countries. And when you look there in detail, actually the only one who has a benefit from autologous transplantation is the angioimmunoblastic T-cell lymphoma. So that subtype seems to benefit from autologous transplantation. The anaplastic lymphoma, the DLCL and the PTCL don't seem to benefit from autologous transplantation. And this is also confirmed by a very recent meta-analysis showing that actually there is only benefit from those consolidation therapy with autologous transplantation in the ATL subgroup. So most studies use the older terminology. So I use the terminology which is used in those publications, but of course we now should call it according to the new classifications. Salvage therapy, so if patients relapse or if they are refractory to the first-line therapy, then you can see that their prognosis is very, very. This is a retrospective single-center study, but you see that actually the prognosis is very poor, whether you give chemotherapy, ICE, DAP, ASAP, Chemox, GDP, whatever, or whether you do in second-line autologous allogeneic, prognosis is very, very poor. And this is also confirmed by the International T-cell project, in which they looked at the relapsed or the refractory patient, and then you see that the only one who have a better prognosis again are the ALK-positive anaplastic large cell lymphomas, which is also probably due to the age of the patients. So are there new therapies? And recently, I don't know if you have noticed it, but in Hematologica there was a real nice series of on T-cell lymphoma by different world experts, and there are a lot of new and promising treatments. Of course, I won't talk about all of them. I will focus on the CD30 part, on maybe some kinase inhibitors, epigenetic therapy, and then also the checkpoint inhibitors and the cellular therapies. So CD30, Thomas already told it, very important antigen. In healthy individuals, it's only expressed on activated B and activated T cells, but in malignant cells, there are a lot of subtypes, lymphoma subtypes, the Hodgkin lymphoma, the ALCL, also primary mediastinal B-cell lymphoma, and also on some non-hematology tumors like germ cell tumors and seminoma, you can see CD30 expression. And of course, this has led to a lot of interest in targeting CD30 in the treatment of those lymphomas. And several monoclonal antibodies have been developed against CD30, both unconjugated, so just the antibody, but also coupled to a chemotherapy, which we call the antibody drug conjugate. And the one who actually was most successful is brentuximab vedotin. So brentuximab vedotin is an antibody drug conjugate. It's an anti-CD30 antibody coupled to an microtubule inhibitor. So when the CD30 antibody binds to CD30 on the cells, the complex is internalized, and there it will release the chemotherapy and the cell will be killed. And this was also already told by Thomas. If you look at the different T cells, ALCL, both ALK positive and ALK negative, are characterized by expression of CD30 by almost all cells. In PTCL NOS, it's very heterogeneous. You have about 60%. You have depending on which publication, but not in 100%, but in somewhere between 50 and 75%. You have CD30 expression. The ATL about 60% and so on. So it's especially in the anaplastic large cell lymphoma that you see most expression. And there have been, I won't go into detail, but there have been a lot of studies, the phase 1, the phase 2 in relapsed refractory patients with brentuximab monotherapy showing encouraging results. The only drawback is, of course, that it has one side effect or one major side effect, and that is the peripheral neuropathy. And this has led to a phase 3 trial, excuse me, the Echelon 2 trial. It's a randomized trial, a phase 2/3 trial, which randomized patients with CD30 positive T-cell lymphomas to CHOP, the classical CHOP chemotherapy, and brentuximab vedotin, which is now called Adcetris, that's what the A stands for, together with CHOP without the vincristine, because we know vincristine is also causing the neuropathy. And then you see these are the 5-year results, that you actually have an 5-year overall survival and 5-year progression-free survival, which is significantly superior, and especially in one subtype, and that's the anaplastic T-cell lymphoma. And here you see that when you look at the anaplastic T-cell lymphoma compared to the non-anaplastic T-cell lymphomas, that it's only significant. It's only the benefit is only seen in that subtype. So which patients were included? Patients who were previously untreated and who had CD30 positive peripheral T-cell lymphomas. CD30 positivity was seen as CD30 detected in 10% of the neoplastic cells. And so these were the eligible histologies, and so only the first 2 were the one who were statistically significant. So this is also the group which now has reimbursement in Belgium. I don't know in other countries, but in Belgium, ALK positive anaplastic, systemic anaplastic lymphoma with an IPI score more than or equal to 2, and all the ALK negative anaplastic lymphoma. And you see the neuropathy is seen in 45% of the patients, but it's also seen in 41% of the patients with CHOP. And importantly, at the 5-year follow-up, both in the study in T-cell lymphoma, but also in Hodgkin lymphoma, almost all cases resolved from their neuropathy. So this is now the standard of care for ALCL. For the ALK positive, I think you all know that ALK is an kinase. It's in many cancers there is overexpression, which can be due to a gain of function mutation, like for example in medulloblastoma, but also by rearrangements like in like in lung cancer and in ALCL. And it's a very promiscuous kinase, so it can bind to different other partners. And then if you see, this is a normal CD4 positive T cell. If you have a cell which with an, for example, the NPM ALK translocation, then actually it becomes another phenotype with all the malignant characterizations. And when ALK is activated, this will actually lead to a upregulation of many genes involved in the different hallmarks of cancers. And here you see all the different, or not all, but many different partners of ALK. But the most frequent one is the translocation 2,5, which bind nucleophosmin 1 to the ALK. And this is also the only one who has nuclear staining of ALK. The others have only cytoplasmatic staining. And there are in solid organ tumors, like in lung cancer, there are many ALK inhibitors, which are now standard of care. In ALK positive ALCL, there are some small studies. Recently, there was the phase 2 French trial in relapsed refractory ALK positive ALCLs showing actually promising results. But at this point, this is not reimbursed, and it's only in trials that it's used, especially in adolescents and young patients. Then epigenetic therapy. So I already told some T-cell lymphomas are characterized by epigenetic mutations, and this has led to a study of an HDAC inhibitor, romidepsin, compared or combined with CHOP versus CHOP in patients with previously untreated peripheral T-cell lymphomas. So exact a bit the same concept of the brentuximab study, and unfortunately, this was a negative study. These are the first results in 2022. And you see, actually, there's no difference between the experimental arm versus the standard of care arm. But when you go a little bit more into detail, you see that actually there is one subgroup which seems to benefit, but it was not at that point statistically significant. That's the ATL group. Another unfortunate point is that romidepsin has considerable toxicity. So it has hematological toxicity. So when you look at the cytopenias, they are much more present compared to the CHOP arm. So it's it's actually it's a toxic molecule. But recently there was the final analysis, so the 5-year analysis, and then they decided to look at the subtypes, because they say initially all the PTCLs, but we didn't know about the epigenetic mutations at that time. So we will now do the statistics, which was not actually a predetermined statistic, but they did the statistics for the subgroups, and at 5 years there is a statistically significant benefit in progression-free survival for the group with romidepsin compared to the CHOP. So maybe, I don't think romidepsin, it's not reimbursed in Belgium, it's reimbursed in the States, but not in Belgium. It's very toxic, but maybe some other epigenetic therapy will hopefully lead in the future to improvement of patients with follicular helper T-cell lymphomas. And this is another recent trial with actually no chemotherapy, but only an hypomethylating agent, or a demethylating agent, the 5-azacitidine combined with romidepsin. It's in previously treated patients, so it's in a relapsed refractory setting, showing some promising results in some patients, and especially in patients with mutations of genes which is logical involved in DNA methylation and histone deacetylation. So maybe this combination or combination of demethylating agents with a more safe HDAC inhibitor will also be promising for relapsed patients. Is there any room for? Excuse me? Yeah.
5 minutes.
It's finished.
You have 5 more minutes.
Okay, yes, I'm at last 5 slides. So
okay.
Is there a place for CAR-Ts? We know in B-cell lymphomas, CAR-Ts are standard of care now in second-line diffuse large B-cell lymphoma. The problem for T-cell lymphomas is that it's more dangerous to produce this T-cells, because you have the risk that you will also expand the malignant cells. So there are different trials running, mainly in TALL, but also T non-Hodgkin lymphomas are sometimes included. And this is a very recently publication with the CD5, an anti-CD5 CAR T-cell, showing actually in 9 patients, 3 patients who received a complete remission with 1 ongoing remission. So it's very preliminary, but it's maybe promising. And then the last word on the checkpoint inhibitors. We have heard about the EBV positive lymphomas, so both the TK and KTC T-cell lymphomas, so the nasal type and the extranasal type, and then the nodal ones. And as I already told before, there is PD-L1 upregulation, there is a less or a more stable genome, which is from a clinical point of view a bit controversial, because you would theoretically say, okay, checkpoint inhibition will be very promising because of the PD-L1 upregulation. But on the other hand, when you look at, for example, colorectal carcinoma, the genomic unstable tumors respond better to checkpoint inhibition. So we don't know at this point whether checkpoint inhibition really is a promising therapy. This is a standard of care for nasal NK T-cell lymphoma, in which we divide limited stage versus advanced stage. So the standard of care is radiotherapy with chemotherapy or chemotherapy alone. But there are some small studies, phase 2 trials or retrospective, showing that checkpoint inhibitors are promising in this cohort of patients. Another one is because it's an EBV-driven lymphoma that you give EBV-specific lymphocytes. This is a study including 10 patients with NK T-cell lymphoma who received standard of care, were in complete remission, and received a consolidation with autologous EBV or EBV cytotoxic T lymphocytes against LMP1 or 2, because that's important. We have for PTLD, for example, we have now tabelecleucel. It's a third party, but it's actually against the most immune dominant antigens, which are EBNA2 and EBNA3. And remember, Thomas told this is a latency 2, which has no EBNA2, no EBNA3 expression. So you need to target in these patients, if you use EBV-specific lymphocytes, you need to target LMP1 or LMP2. So this is my conclusion. So optimal frontline therapy, SHOP is in most cases still considered the first-line therapy. Is there a need for consolidation therapy? Autologous transplantation seems to benefit patients with angioblastic T-cell lymphoma. Salvage therapy remains very, very disappointing. And for the new treatments, so the antibody-drug conjugates are used in ILCL. So we don't use etoposide because etoposide was also benefit for patients with ILCL, but of course the data of the 5 years data from the Echelon-2 trial were so impressive that we use those. We now use brentuximab. The kinase inhibitors can be used maybe in the future for the ALK-positive ones. Epigenetic therapy for the follicular helper T cells. Cellular therapy, maybe the CAR Ts, if we have some more research on it and more studies. And then the checkpoint inhibitors for EBV positive. We are not sure about that at this point, but maybe in the future they can help. So this is again my question. So, but we already know the answer. So I told you that brentuximab vedotin combined with CHP in ALCL is now the standard of care. So that was the one which has a superior 5-year progression, but also superior 5-year overall progression. The rest is not at this point convincing enough to say that it's statistically significant. So I thank you for your attention, and of course, I'm happy to answer your questions.
Thank you very, very much, Dan. I think you have given an impressive overview of the therapeutic options and made very clear that we as pathologists should classify the lymphoma as accurately as possible to ensure critical inclusion, to include proper inclusion in the clinical trials. In the sake of time, I would suggest the audience to put their questions in the Q&A section, which we will address later on. And
thank you to Yasmina for her remark from in Holland. Hi, Yasmina.
Okay, thank you very much. And I will proceed now to Professor Marcus Tiemann, specialist in hematopathology at the Institute of Hematopathology in Hamburg. He's a founding partner, managing director. He put up a few subsidiaries doing molecular pathologies in other cities. In short, very, very busy man. But he has found some time to share us his experience in practicing and teaching hematopathology. And he has a large number of years of experience and considered an expert on the pathology of Morbus Castleman. And Marcus will give us some clues how to become aware that we are in the labyrinth or woods, if you would like to, in the first place. How do we know that we are dealing with a T-cell lymphoma? Marcus, the web space is yours.
Thank you, King. I think we should try within the last half hour to dive deep into this labyrinth, but according the lines of the diagnostic path, we can go on. These are my disclosures, and we hurry up. We hurry up with the first case, a 49-year-old male, and he showed unclear foci within the right lung. suspicious from radiology for lung carcinoma, and showed also enlarged lymph nodes in neck level 2. These are the first slides, but we will try to use our digital microscope. And case number 1. Here you can see the focus from the lung tissue. Remembers to a lymph node, but there is no preserved normal architecture, no B follicles, and no stereoscribe macrophages, nothing. And then we have this is the lymph node from the neck, here shown in the Giemsa staining. And you see, here's the capsule. Really no normal follicle centers, only remnants, and mixture of cells within the pulp with eosinophil granulocytes, some larger blasts, many small or medium-sized lymphatic cells. So it's a little bit confusing. What do you use? If you are confused, you should use the CD20 staining. I will leave the H&E staining for you on the left side. And on the right side, we will have a short look for CD20. This looks a little bit strange. You see, there are remnants of B follicles, but they are not germinal centers. And they don't look malignant, but they seem to be invaded from the periphery by a group of cells CD20 negative. This is one point. Then we look on the opposite. We look for CD3 for the T cells, and we see most of these smaller lymphatic cells are T cells. Smaller ones, and then this a little bit larger and more faint stain, showing a more faint staining of CD3. This look like malignant T cells. And then the next look we should take the next view to the FTC networks. And here you can find different patterns. One shows this invasion of the T cells from the periphery of the former germinal center. And here it looks like an explosion has taken place. Only the ruins or the rest of the FTC networks is to be seen. And then we can find these extended networks, like here. Large extended networks with non-sharp borders. Maybe this is a sort of bursting or explosion of the follicle center. And the next step would be, can we see the same in CD23? And this is more or less the same. But CD21, as you have seen, is a little bit better to discriminate. The next step is, what sort of T cells are these? Do they have CD4? The answer is easy, yes. The whole lymph node shows effacement of the architecture, shows effacement by CD4 positive T cells. And the next, where we will look for CD5, is there a certain antigen loss? Not really. Maybe 10% of T cells are not showing CD5, then CD8. Surprise. This is not a lymphoma of cytotoxic T cells. Most of these T cells show CD4 positivity. And another hint will us give PD1. As Thomas already have shown, you see at least half of the tumor cells show PD1 positivity, some more faint positivity as shown here, and more some with more dense expression of PD1. Then we have only few points left. Is there CD30 possibly to be to be seen, and this is very striking in this case. There's one focus showing an increase of CD30 positive blasts. This is very unusual, but there are not closed sheets of blasts. So this is, of course, not a ALCL lymphoma, and the blasts are smaller than the blasts of an ALCL lymphoma and do not show cohesivity. Where CD30 can be seen, there must be a look for EBER, and in this lymph node, EBER, yeah, there is some EBER left. You can find it. Strong nuclear staining of smaller cells, some blasts, but this is not comparable to EBV positive NK cell lymphoma. But EBER is associated in this lymphoma. And of course, Ki67, moderate proliferation, maybe around about 15 up to 20%, but not very strong. And this is just to ask you, what would be your opinion with all these theoretical implications you had gained within the last hour? Perhaps you can write some ideas on the chat, and in between we will go back to the presentation. So this you have already seen. CD2 was also positive, CD3, CD4, CD5 partially, CD8 more or less reactive T suppressor cells. Oh, I omitted partial CD10 expression within the tumor cells, but not so many, maybe 10%. And this is the striking pattern of CD20, the more or less diagnostic pattern of FTC networks. And this is CD23, CD30 again, and EBER. These are eosinophil granulocytes. The nucleus is negative, but here the nucleus is positive, and here, so there is an association of EBV infected cells. In the end, we have this list. You see CD2, CD3, CD4, CD5, CD7, partially CD10, CD20, and these all the other cells, sometimes stimulating the growth of these specific T cells. Any idea? Some opinions within the chat, King?
I read one, angioimmunoblastic T-cell lymphoma.
Yes, very good, very good. So real experts are hearing us.
MA8.
This is the analysis of T-cell receptor rearrangement. This is obligatory, as Thomas told you, in this group of lymphoma, and you can find here 25% of the cells showing a rearrangement of the beta chain of the T-cell receptor and two different rearrangements of the gamma chain of the T-cell receptor. And we could find a row A mutation, and you have also this that was shown by Thomas already, the G17V mutation, and an additional mutation of the PBXW7 gene. So, but this is more or less diagnostic in this group, and this is just one short glimpse what the NGS-based rearrangement can show to you. This is here the main clone, and the same size is shown by several reactive T-cell clones. And this is the other clone. This is the gamma rearrangement, and you see all these reactive cells showing the same size, but similar rearrangements. These are only reactive cells. And for the beta chain, it's more clear-cut. Here is the main clone, and these are reactive T cells. In this lymphoma group, there are always mixtures of cells. So angioimmunoblastic T-cell lymphoma, you have to store in your mind, or if you want to look again to the slides, just store in your mind the FDC network pattern and the immunophenotype with CD4, PD1, and CD3. This is good. And the peripheral invasion of the germinal center cells and the, I think, the mixed pulp with mostly smaller or medium-sized and some intermediate blasts. This is very typical, even with this mixture of eosinophils. Very typical case. One of the most important primary nodal T-cell lymphoma. And my hope is, and Dan Diericks has shown this in the end, this lymphoma type shows very often high expression of PD-1. My hope is that this could be influenced in therapy by a combination of PD-1 antibodies with a conventional chemotherapy. Okay, this was case number 1. Now we switch to case number 2. This patient is much more older and showed fever for several weeks, fatigue and night sweat, and enlarged but painless cervical and axillary lymph nodes. This is an overview of the H&E, and I will again switch to the next case. Case number 2. I have only a Giemsa staining, but you see in the large overview some remnants of germinal centers here, here, and here, but most of the area of a lymph node is destroyed by a certain type of lymphoma. In contrast to the last one, a similar size of atypical cells with round nuclei, some mitosis, atypical mitosis, so looking very malignant. And here you see some biasing your thoughts with a CD2 staining. They are strong stained, possibly persisting reactive T cells, but these weak stained cells are larger and they look very malignant, or at least very suspicious for a malignant T cell lymphoma. And then CD3, you see these larger cells with the slightly indented nuclei, and these are of course not normal T cells. And you see again in the conventional staining these cells. Okay, so short, we go through the T cell stainings. CD4, strong positivity. CD5, also no antigen loss, but strong positivity. CD8, oh, surprise, negative. So clear-cut T helper phenotype. CD10, only remnants of the follicles, of the follicle center cells here. This is a germinal center, follicle mantle, and here are the tumor cells in this area. You can compare this very easily with CD3. I think this is the part, and you see a narrow rim of the follicle mantle, some tumor cells possibly entering the germinal center, but the most others growing around. Okay, do we have PD-1? This is PD-1. Strong positive TFH cells within the reactive germinal center, but the others with faint stainings are surrounding this. Very typical pattern. And then CD23, again some remnants of germinal centers, but not with onion layers. Here the cells are already invading the peripheral zones of the germinal center. This is a very typical pattern. Key 67, there's somehow proliferation, stronger than as in the last case. So you can expect more clinical progression and more worse clinical course. This is somehow around, if you count the strong positivity, 40%, otherwise around 60%. Okay. Just for remembering, you see this CD3 positivity and the follicle centers left, CD4 positivity, CD5, CD8 negativity, CD10 only remnants of germinal centers, and CD20 most of the follicles are preserved, some are destroyed as shown here, and the tumor is going around the germinal centers. And this is CD21 showing the same pattern, CD23. This is the high proliferation area, and there are other areas with lower proliferation. This is the T cell receptor rearrangement pattern for clones with rearrangement of TCR beta and 2 different rearrangement of TCR gamma. This is again the phenotype. CD2 is more faint, but CD3, 4, and 5 are strongly expressed. CD8, CD10 negative, and here different pattern of proliferation with slow proliferating areas and high proliferation in some areas as shown. What's your opinion? What's the difference between this case and the last one? The last one was growing from the periphery within the germinal centers. This tumor is growing around the germinal centers. Any ideas? Some ideas written in the chat, King?
No, not yet.
No.
Only a question about the group of CD30 positive cells. I think that was on the previous case on the APL.
That could be an active focus with more EBV association, but it's not mirroring a transformation of the lymphoma, not with this single cell stained pattern. Okay, again, T cell receptor rearrangement.
This is PTCL NOS.
We are entering the scene. Very good, very good. This is again here the TCR gamma rearrangement, 1 clone here, and you see only very few rearrangements from the reactive cells. This is much more clear than on the cases before, and here another rearrangement with a different size. And exactly, you're right, peripheral T-cell lymphoma not otherwise specified. Maybe in later times this can be named, but at the moment we have no specific category for this type of lymphoma. Okay, perfect answer. Next case.
1 long case or 2 short cases, Marcus?
Okay, short case means 5 minutes per case.
Well,
we will accelerate. Okay, here with this 74-year-old male, there was an undulating fever for several weeks, fatigue, night sweat, many enlarged lymph nodes within neck, axilla, and groin, and showing this pattern. Some remnants of germinal center, here, also here, and here, but not as strongly destroyed as in the cases before. We go again to the slides. Case number 3. This is our HNE. Here, some enlarged high endothelial venules, and germinal centers are a little bit strangely changed. There are diminishing blasts, many small cells within these germinal centers, and thickened vessels. This is CD2 of the same lymph node, many T cells, but Sometimes they are lining the high endothelial venules. CD3, more or less the same pattern. And then, no idea what's happening here. We switch to CD20. And then we see this somehow strange, changed germinal centers with thickened vessels included. Here, the number of blasts is decreased. And in CD21, we will look for several patterns. And you see this onion-like FTC networks. Here, very typical. But not in all germinal centers. Here, but some are looking reactive. And then this looks a little bit destroyed. Okay, then short look for CD10. And our impression, this germinal centers are, they have a decrease of blasts is mirrored here with this only 10% of the numbers of CD10 positive cells within the germinal centers. CD20 we would have already. And then this CD30 positive blasts surrounding some of these germinal centers, and PD1, lots of cells included. The first question is, do you see a changed but all in all preserved ground architecture of the lymph node? The second, have you seen really malignant B or T cells? Looking here again, maybe this is a little bit larger, but that was a germinal center. Now within the pulp, here are these, just from the conventional cytology, malignant T cells or not? You should think it over, and we will go back to our presentation. Just remembering some changed germinal centers, and then this pattern, the T cells you have seen CD2, CD3, CD4, CD5, CD7, CD8, more or less reactive. And then you see there is a clonal receptor. There's a clonal T cell receptor rearrangement. There's no row A mutation. And we have, again here, in the last lymph node, T cell receptor beta, T cell receptor gamma changing. This was in a former biopsy seen in a bone marrow trifine, get your pardon. And this is the pattern you see here with oligoclonal T cells, not really clonal. Maybe this clone is larger than others. This could be a transition. And this is the gamma chain rearrangement. It's more clear. You see here and here clonal rearrangements, and here you can find these reactive rearrangements with the same size. What's your idea? Is it a T cell lymphoma or not?
There is a suggestion of a FPT.
Prison or success? Prison
Yeah.
or career? Any idea? This is a very early stage of a TFH lymphoma. So my final diagnosis was peripheral T cell lymphoma of germinal center dependent T helper phenotype, so TFH. And this was underlined by the clonal rearrangement.
It is
Do we have
suggested.
time for one final case, Ging? Last but not least, we go.
Do it in 5 minutes.
Yeah, we will do this. Again, you see this well-preserved lymph node. I go back to the microscope. Well, that was case number 4. And again, in the H&E staining, you see well-preserved germinal centers, but not with this decrease of blasts. They look more or less normal, but not the number of smaller cells is increased. Of course, the follicle mantle are to be seen. They are well preserved. The sinus are here. So the architecture seems to be preserved. And then in CD20, you see most of the cells are B cells. Widened follicle mantles. The next step would be CD21. And we go here, we dive into this lymph node, onion layers around germinal centers, diminished blasts, here too. And CD23, the same pattern. Again, some of these germinal centers are changed. I think this is enough. We can go back to the former presentation. Again, CD3 pattern, the architecture seems to be preserved. These very striking FTC networks known as onion layers. And then we see CD3 positive T cells, but in well-preserved architecture, CD20 positive cells, also in well-preserved but changed architecture, the increased numbers of FTCs and this specific pattern, and the light chains of the plasma cells in the pulp, and the follicle mantle cells had been B-typical, so polyclonal. This is a typical example of an early stage of a multicentric Castleman's disease, only partial infiltration of a lymph node. And you see, if you look this in comparison to the angioimmunoblastic lymphoma, you will never mix up reactive or Castleman's disease with angioimmunoblastic T-cell lymphoma. The exploded networks and the destroyed networks of FTCs of follicular dendritic cells are a striking pattern. And with this, as I promised, I will end the presentation. The last 3 cases will possibly show within some of the next seminars. And I will, for the final words, the final words are always spoken by a priest or a pathologist. So the final words are now dedicated to King Lam.
Thank you very much for your presentation, Marcus. As always, too many cases for not so much time, but it was very illustrative. Anyway, we have 5 minutes for the short discussion, and I want to pose one question to you as colleagues, pathologists, and perhaps also as a clinician. How many times, and I'll answer honestly, do you resort to gene rearrangement studies to make a diagnosis of T-cell lymphoma? Do we need the gene rearrangement study to make the diagnosis of T-cell lymphoma? And for the clinician, do you accept a diagnosis of T-cell lymphoma without a report of a gene rearrangement study?
Well, I think, like I showed in some of the cases, when you are in doubt of your origin, your cell of origin, and you want to confirm that it's of T cell origin, then it's very supportive if you have T cell clonality, of course. But yeah, as we all know, clonality does not equal malignancy and reverse. So it's always interpretation within the complete morphological and clinical picture. I don't think that you can just make a diagnosis of T-cell lymphoma based upon clonal T-cell rearrangement.
But do you issue a pathology report without T-cell rearrangement and stating this is a T-cell lymphoma?
Oh, if it's a clear lymphoma, yeah, sure.
Okay. I think you need both the changed morphology or the different immunophenotype, and then the T-cell receptor rearrangement. I think it's a standard of confirmation of your morphological suspicion. I learned from my old chief, Karl Lennart, you need no molecular genetics, it's only morphology. I think this is wrong in our times. We have to use every method to confirm the diagnosis, because the therapies are sometimes dangerous. They are life-changing, and we have to generate the most safety for the diagnosis. The most safe criteria must be used, and then we as responsible pathologists, we can give a good basic information for the decision of the clinical which therapy they choose.
And what's the take of the clinician?
Yeah, we rely on Thomas, of course.
Of course.
If the morphology and the phenotype is clear, we don't need the TCR. Even if it's not clonal, it's a lymphoma for us. The most difficult one is if Thomas says I don't know if it's a lymphoma, and then there is a clonal PCR. We like Thomas said, it's not enough for us. Then we try to have a new biopsy, or to, if we can wait, we wait and see how patient progresses, or if it disappears, if it's reactive. But it's a combination, actually, like Marcus also tells me.
Okay, very fair enough. Then I have another question, because we have 1 minute. What is your take on the new markers TBX21 and GATA3? Do we have to start performing that on our tissue?
Well, like I said, we have the data available on the molecular subtypes, and it's a bit like what we used to do on DLBCL, the Hans algorithm. In order to differentiate ABC from GCB, it has some indication, but it's not definitive. And now we see that mutations are spread over the different molecular subgroups. So it might be, but more from an academic side or kind of view, to start doing them, the molecular subtyping of PTCL and OS. But it might, I mean, at this point, I don't think that the clinicians will require this, and in order to perform a different treatment. No, what is your opinion, Dan?
No, we don't have different therapies for it. It just tells something about prognosis, but there's no therapy for it. No.
Okay, thank you.
In Germany, it's very easy. Prognostic markers are not be paid, so no reimbursement. You can, if you're interested in, you have to pay it by yourself. So nobody does. And the second is predictive markers are well paid, and this is, I think, a good decision. There's limited number of money in the health system, and you have always to prioritize your markers and your analysis.
Okay, with this, it's 7 o'clock. We have to close the seminar. First, I want to thank all the 3 speakers. I think you have done a wonderful job. I've learned a lot, and I have quite a lot of experience. So even then, I have learned a lot. So thank you very much. I thank the technical assistants from Smart in Media, and this represented by Mona. Thank you very much for having us to do a wonderful technical job. I also thank Ricordati Rare Disease Group for sponsoring and especially also organizing this meeting and to put the experts together. And of course, I also thank the audience for being patient with us and bear all the very detailed, sometimes very detailed data. The last thing I want to say is please fill out the survey, which will be sent to you shortly as soon as this webinar closes. We need the input, and the last I would say is thank you again all very much. Take care and have a nice evening. Bye.
Bye-bye. See you next time.
See you next time.
Bye-bye.